Okay, so now we're going to do part 2 of the module on sustainability. So building off of the first module where I introduced a lot of the definitions and conceptualizations in this area, now want to talk about some of my work and some applied examples. So this is the National Witness Project. These are the community partners and lay health advisors and leaders from across the country that I've been partnering with for almost 10 years. They are an amazing group of, again, lay health advisors who really found that it originally developed in Arkansas in the early 90s from cancer survivors, African American cancer survivors, who were women, who felt like their needs were not being addressed in terms of being able to access cancer screening services and navigate the system. And they felt like they had huge structural barriers and weren't able to really, didn't feel like they had the resources to support women in their community. So they developed this program where they train African American women. About half of them are cancer survivors, and about half of them are lay health advisors who help provide kind of education, resources, empowerment messages, social support, systems navigation, in terms of getting through, kind of the screening, access to care, and then navigation, communication with providers. And then if they are diagnosed, kind of helping them do some of the diagnostic follow-up and navigation as well. So this was really a community engaged program designed to really meet the cultural needs of what they saw at the time as a group of medically underserved African American women. And again, they really felt like the issues of stigma and mistrust in their community were not needed to be addressed and needed to be addressed by women from the community. So this program has now been in place and nationally implemented and disseminated for about 25 years. It's been in, across 22 states. It has a huge group of both volunteers, some are who are paid, some are who are volunteers, and they reach about over 15,000 women per year. And this is one of the National Cancer Institute's research-tested intervention programs. So as I mentioned, that huge resource of a database, this is one of their evidence-based programs. So what I found when I started partnering with them, I was really interested because lay health advisors and community health worker programs have been highlighted as a really important strategy, highly effective for addressing disparities. There's been a lot of evidence for both African American and Hispanic women in the U.S. for cancer screening, but really for a range of issues related to mental health, related to access to care. We're now seeing this model globally implemented. So again, these programs have been highly disseminated, but we often know little. When I went to the literature, I knew nothing about who are these lay health advisors. We often focus, or researchers often focus on the impact of the programs in terms of the attendees, but I wanted to know who the women were, what was their motivation, what supported them to be in the program. And the Witness Project said, that's great, we'd love to partner with you. And they said, but for us, sustainability is a huge issue, and we'd like you to help us understand that. So we wrote an R03 grant to the National Cancer Institute that was funded to try and address these issues. And I'm not going to go into depth, but I just want to highlight a few of our findings. So the first paper that we published in Health Education and Behavior was really focused on what are the characteristics, what's the capacity of lay health advisors in these community settings, really with an eye towards trying to understand who are the women who take on these amazing roles, what's their motivation, what are the things that they need to be successful in terms of trying to implement these programs. Here is the group of the original women in Arkansas who developed the program. And what we found, if you want to look this paper up, is we found that women receive huge benefits, and we found that the greatest benefits received by the lay health advisors are from those who themselves are cancer survivors. So they're the ones who get the networks, the knowledge, the self-efficacy, and they really get a sense of empowerment in terms of being leaders in their community. So we saw across the board many women receive benefits, but especially the cancer survivors. And we also found that what often motivated people to initially be in the program as a lay health advisor or peer was either a personal experience with cancer or an interest in addressing disparities in their community. But we found that what retained them, often what they reported as keeping them involved over time, and many of them had been in the program, I think on average 5 years, and for some of them up to 16 years, was really the sense of the social support and network that they developed of this amazing group of women who were working to address kind of this common goal in their community. And I think, again, particularly for the cancer survivors, having this network as cancer survivors, some of them were re-diagnosed, some of them had to navigate other health challenges, but they had this network and support in place. And it's also important to recognize that there were challenges. Some of them, especially the smaller sites, experienced burnout. There was a lot of issues around thinking about financial incentives and social recognition and ways to support them. But I think this paper starts to provide some insight into who these women are as key implementers and leaders in their community. Our second paper this is an implementation science, looked at again, they were having this issue of sustainability and huge turnover. So they found that about 30 to 40% of the women annually would get trained, but then many would drop out. And they said, we want to understand what can we do to actually support women to be active and retained in the program. So we looked at this. Based on some of our initial work here, we came up with what we identified qualitatively as some of the important factors that might matter. And what we did is we looked at these factors in terms of their motivations, individual level factors that might influence their involvement and retention in the program, social factors, and then kind of organizational factors, their role benefits and challenges, their kind of self-efficacy, their knowledge, their role expectations, their job satisfaction, etc. And we wanted to see which of these factors at various levels matter in terms of actually predicting whether or not they stay in the program. And again, we found that we did find, similar to what they thought, about 30% of the women dropped out. And again, we followed them over 2 years, about 80 women across 80 sites. What we found is that the most important factors of whether or not lay health advisors remained involved and active in the programs was whether or not it was really the organizational factors. It was whether or not the lay health advisors were based at sites that had a strong partnership with either an academic institution or a cancer center. So lay health advisors who were based at non-academic sites had an 80% decrease in odds of being active than LHAs who either had a strong partnership or relationship with an academic site. So sites with the academic partnerships were more likely to hold regular trainings, provide a stipend, have a steering committee or board in place, and have a physical infrastructure for the program. And we also are kind of finding anecdotally that the sites that had this strong partnership, they were also getting capacity building, like grant writing expertise. When there were gaps in funding, they were getting coverage and some of the resources and infrastructure for the program to keep it going, even in those years where they might not have specific funding support. So one potential strategy for kind of supporting sustainability and specifically kind of retention of lay health advisors might be not only to think about community champions, which we already know are critical, but thinking about that community academic partnership and thinking about identifying academic program champions as well who can champion the program and maybe help address some of those resource gaps or think about ways to build capacity for the communities. We also found that the longer time someone was a lay health advisor, the less likely they were to remain in the program. And this really gets at the need for either financial incentives or social recognition. So we heard a lot about lay health advisors needing support to prevent dropout or burnout. And again, for some of these sites, they were able to provide minimal financial incentives, but often women reported just being recognized as leaders in their community was also very meaningful to them. We also found that having clear role expectations was associated with higher retention. So one important strategy might be really clarifying role expectations at initial and ongoing trainings in terms of what's involved at the role, in the role, and kind of what they'll receive from it. And role self-efficacy was also associated with higher activity levels. So again, providing opportunities for lay health advisors to increase self-efficacy through training and feedback. We've heard this again and again and again from the sites, that training not only provides those skills, but also the social connection that keeps women highly involved. So our third question was a little more qualitative. We wanted to get at, again, from the perspective of the lay health advisors and the project directors, what factors actually influence the sustainability of these sites. So again, we started kind of broadly with kind of the same levels of the Consolidated Framework for Implementation Research, the CFR, and we just kind of probed at each of these levels what mattered for sustainability. What we found is that we kind of thought we would have sites that were highly sustained or not, but what we found is that a lot of these lay health advisor programs were highly dynamic. So 60% of the sites in the past 5 years had experienced periods where they couldn't offer programs. So again, for 1 year, they might be highly active and then inactive. So again, this suggests and kind of reinforces that idea that sustainability, even within a site, could be dynamic. And a lot of the barriers, again, related to funding, limited organizational infrastructure, to have this, the space, the printers, to have the programs, the national leadership being supportive of the local sites, and not having opportunities to build evaluation in to really document the impact of the program, as well as LHA burnout. And at this point, almost all the sites provide some kind of financial incentive. So again, this suggesting that, that's important, but there's other factors that need to be addressed. In terms of facilitators, again, having strong organizational partnerships. As I mentioned, this was important to have this with academic and cancer centers, particularly because they're trying to connect them with cancer screening. But this also included community partners. This was often churches. Some were housed within departments of health. There was lots, the networking and the maps in terms of their partnerships is extensive and impressive, and was part of what having those in place helped sustain the programs. We also saw that the project director was kind of that champion at the community level that was absolutely critical to have in place. So we saw that when there was turnover in the project director, it also had huge implications for sustainability. We saw that something that, again, facilitated the sustainability of the program were the benefits that lay health advisors got out of this, their commitment and their kind of the empowerment they experienced, as well as, again, the social networks. Many also talked about the professional and career advancement that they experienced through this in terms of leadership development, communication development, being able to navigate health systems. Some of them who left, they saw this as kind of a springboard. So it may have looked like they were dropping out, but in fact, they used this as an opportunity to gain some skills that they then applied in a new area. Again, this program was seen as being really critical in terms of addressing a need within the African American community that, and other programs did not really address that need. And again, the powerful role of cancer survivors, I think, is absolutely unique and critical in terms of sustaining this program. I think they are really kind of the engine that kind of drives a lot of the success of the program. What we did is we took our quantitative findings in terms of what kind of predicted the retention of the lay health advisors, and then we took these qualitative findings, which are all reported in Translational Behavioral Medicine, if you're interested in reading more about kind of the quotes and our methods and our findings. And what we did is we created and published a lay health advisor sustainability framework that kind of brings together in a mixed methods way, again, what we heard from the site was important, and what we found kind of predicted retention of lay health advisors and their involvement level. And so what we've now done is we have a grant from the American Cancer Society that's actually going to be looking at this among the sites nationally, again, both qualitatively and quantitatively. So this will be a larger prospective study of this. So in terms of thinking about moving the field forward, in the American Journal of Public Health in 2019, we published kind of what we saw as some of the key areas to advance the field in sustainability. So again, there's huge gaps in terms of what we know. What might we be able to do to think about improving our knowledge base? So again, thinking about sustainability as a dynamic construct, and just as we've talked about throughout the course, that we're not thinking about this as kind of static, high fidelity, but we're thinking about planned adaptation and response to changing populations, evidence, and contextual influences. Ideally, we're studying sustainability from a multi-level mixed methods perspective, just like we talked about with studying implementation, getting the perspective of various stakeholders, getting what their perspective and input, and ideally prospectively, so that we're not asking about this retrospectively, would be really important. I think we've talked about implementation strategies and implementation science, but we have not even begun to think about sustainability strategies that we could test. So again, some of my work in the community settings has suggested what some of those might be, but we need a lot more work in this area. There's huge opportunities for thinking about policy sustainability. I think you can think about applying a lot of the same lens and conceptualization to policy as we've done with programs. This is an area that really hasn't been touched. And I think finally we're on the same page in terms of a definition of sustainability and some of the frameworks. So I think working from these definitions and testing conceptual frameworks is a future direction. So one thing we did in our annual review of public health was we went through almost 300 articles on sustainability, and we started to identify across settings, across intervention types, across populations, what are the factors that seem to matter for sustainability? And we pulled those together in what we call the integrated sustainability framework. So again, in the outer context and the inner context related to implementation processes, characteristics of the intervention, and the interventionists themselves, what seems to matter. And again, what we're suggesting that people do is use this as a starting point and then adapt for your specific context or setting or population qualitatively as you do some pilot work that you can then use to kind of inform, adapt this, and test this. So again, this is meant to be a starting place based on some of the empirical literature that you can adapt and test. The other thing we did in our review article was we started to think about different settings. So community settings, school settings, clinical settings, global, whole systems, and coalitions. And we went through all these various factors at various levels and said, are there certain factors that might matter more for some settings than others? And so this table is also in our annual review article if you want to take a closer look. But just one example. So we found on the literature in global context and sustainability that adaptation and engagement of partners is critical, and it may be particularly critical for global settings, particularly where you're often having to kind of start from scratch in terms of what the intervention in setting might look like. In the settings with a strong organizational unit, so maybe clinical settings or schools, we find that staff turnover and attrition and that organizational infrastructure are critical in terms of sustainability. For community settings, we've often found that, again, stakeholder engagement and actually proactively planning for sustainability is particularly important. So we're starting to see in certain settings that certain factors might be more important than others. And again, there's lots of unanswered questions for sustainability. You know, do all these factors matter all the time? Which factors matter more? Can some factors compensate for funding? And again, are the factors that matter for implementation the same that matter for sustainability, or are they different? So these are a lot of the questions that people are starting to think about. In terms of the time frame, if you're planning work in this area, again, for sustainability, I typically recommend that you're looking at least a year out past implementation, and ideally you're looking at this over time, kind of annually. I think you have to work with your stakeholders to determine how are you conceptualizing sustainability? What's meaningful for you? Is it the continued impact on health? Is it the continued delivery? Really thinking about that, and again, making decisions in collaboration on that. And then again, thinking about what are the strategies you might be able to test that could impact and actually promote sustainability. So one area that's kind of evolving here, that's come out of this area that's related, is this issue of de-implementation. So this is really about, thinking about the removals over time of interventions or programs or guidelines that are either no longer supported by scientific evidence, are unnecessary or costly. So there's a whole area of work that's developing and implementation in this area. This has been relevant to my work in community settings with the National Witness Project, because when the original program was developed, many of the screening guidelines that were in place 25 years ago have completely shifted. So if you just look here, even in the past couple years in terms of national guidelines for screening, even the organizations themselves are inconsistent in terms of the age to start mammograms, the interval, and whether or not breast and self-exam and clinical exams are recommended. 25 years ago, when the community partners that I'm working with developed their programs, again, the intervention intervals were completely different for screening, and breast self-exam and clinical breast exam were recommended. So I wanted to understand, how are they adapting or not to changing guidelines over time? What we found in some of our pilot work is that most women, mostly health advisors, are keeping the original program core components. They are not necessarily adapting it, but they are aware of the new cancer screening guidelines. They're aware that breast self-exam isn't recommended and that clinical breast exam isn't recommended. But what we often hear is that they feel like the screening guidelines have changed multiple times and that it's inconsistent across organizations. So they feel like if they finally get women in the community on board, it's just going to shift again. And they feel like at that point, having to go back to African American women in their community and explain that it's changed again, that they're going to kind of set up and kind of create possible mistrust, where there's already mistrust of a lot of these guidelines. So they really see this as an issue where they continue the breast self-exam, not necessarily as a screening tool, but as an educational and an empowerment tool for African American women. So it brings up some really interesting issues about thinking about changing scientific guidelines over time, and whether or not programs shift, and kind of who makes that decision. If it's a community-delivered program, often they're the ones really at the end of the day who make that decision. So thinking about kind of how that aligns or not, and kind of the justification for that, I think is really, really interesting, because a lot of the things we might be studying to de-implement, you might not have kind of the buy-in of the patients or the providers or your community partners. So thinking that through and kind of the justification for de-implementation, I think, is really interesting. And just a note here, again, African American women, the lay health advisors, often they have the perception that even though now there's kind of a shared decision-making approach for screening for ages 40 to 49, because they are often diagnosed earlier with more aggressive tumors, they are often recommending that women in their communities still start screening at age 40. And again, they don't want to be left behind if the evidence changes again. We also looked at why a lot of the sites and lay health advisors aren't necessarily adapting to the new guidelines. And again, what we heard is that trust and mistrust among both the lay health advisors and the community members is really critical. Many of them do not trust the changing guidelines or the organizations, again, because they've been inconsistent, because they've changed over time, and because they feel like they might be left out if they're changed again. So I think the mistrust issue in community settings is critical and often not considered in our implementation models. And I think it's important to think about from a health equity perspective. So I think, just to wrap up, I think when we're thinking about sustainability, I think it's much more complex than I originally thought. I often thought it was just about sustainability. Now it's often thinking not just about sustainability, but also about adaptation and planned adaptation. And when you have changing evidence, potentially even de-implementation. So again, a lot of my work when I'm thinking about sustainability outcomes is much more complex than just sustainability, yes, no. Some of the areas of interest in the field I just want to kind of highlight as we kind of wrap up, because I think we've touched on a couple of them here. Again, this tension between fidelity and adaptation, these issues around sustainability and scale up, issues around de-implementation. I think all three of these are areas that are kind of understudied and of huge interest for the field. As we talked about how to select implementation strategies, we have huge gaps in that area. I think that's another priority area, as is, again, this focus on really what does it mean to have meaningful engagement and really have an engaged participatory implementation science inform our work. Health equity and context, again, have been often underlying and kind of foundational, but not necessarily explicit. So again, focusing the work more is important. And again, we've had a lot of focus in implementation science on interventions and much less on policy dissemination and implementation. So I think these are other areas for the field to advance.